The National Hospital in Oslo is the largest center for functional neurosurgery in Norway. It is the only center that treats dystonia with deep brain stimulation. From 2003, we have treated 20 patients with primary dystonia, of which the first 17 are presented here. Dystonia can be classified according to etiology as primary or secondary accordingly. Primary dystonia is the idiopathic dystonia, where the etiology is unknown although genetic factors are suspected. Secondary dystonia can arise on a variety of reasons, including trauma, metabolic reasons, degenerative disease, ischemic lesions, and the intake of different drugs. Dystonia can also be classified by the affected areas of the body as generalized, hemidystonia, segmental dystonia, and focal dystonia. We have treated patients with both primary and secondary dystonia, but here we present our consecutive series of the 17 first cases of primary dystonia treated with deep brain stimulation in our institution. Deep brain stimulation for dystonia targets the globus pallidus internus, or GPI as it's called. The patient is put under general anesthesia just before the mounting of the stereotactic frame. We use the CRW frame, which has several advantages both in keeping the field strictly sterile and in control of surgical precision. Targeting is done by direct visualization and then related to the classical coordinates. Preoperative MRI and CT scans are fusioned on the BrainLab system. Traditionally, inversion recovery MRIs have been regarded as the best for visualizing the globus pallidus internus. However, proton-weighted series are now the standard modality in our institution, as this seems to give a clearer definition of the nuclei. Planning the trajectories and targets is teamwork, and the exact targets are carefully selected in close cooperation between neurosurgeons and neurologists. The best target is generally accepted to be in the posterior and medial region of the GPI, not far from the passing fibers of the internal capsule. The patient is positioned in the beach chair position on the operation table. After the stereotactic frame has been adjusted to match the planned coordinates, the accuracy is tested on the stereotactic phantom. An accurate pinpoint of the tip of the phantom with the stereotactic pointer confirms the accuracy. This is a reliable and effective precaution in order to avoid human error in targeting using the CRW frame. Both the skin incision and the burr holes are placed according to the stereotactic coordinates of the trajectory. Microelectrodes are then inserted in order to do microelectrode recordings for further neurophysiological verification of the optimal target for the final electrode placements. In most centers, an array of 5 microelectrodes is inserted and accordingly 5 microelectrode tracks are simultaneously recorded. We find that we get all the benefits from an array of 5 microelectrodes with only 3 microelectrodes arranged L-shaped, slightly obliquely so that 2 of the microelectrodes follow the presumed orientation of the nucleus itself. In this way, the optimal findings on recording are solid GPI signals on the central electrode and silent tracks on the medial electrode and the posterior electrode. This gives further confirmation that the central electrode is placed in the very posterior end of the GPI. The GPI has a typical firing pattern with burst-like high-frequency firing, causing a very specific auditive pattern as demonstrated here. After choosing the optimum trajectory, microstimulation from the tip of the microelectrode is carried out. It is vital to observe a sufficiently high threshold for motor response from the capsula interna, as a very low threshold indicates that the trajectory might be a bit too medial. The motoric response might be discrete, as illustrated here. Watch closely the motoric response around the right eye upon stimulation at 4.0 microampere in this patient. After establishing that the trajectory is precisely placed in the target and with sufficiently high motoric response threshold, a permanent electrode is introduced in the same trajectory. Again, the threshold for motoric response is checked. The Kinetra pulse generator and the extracranial leads are then implanted in the same session under general anesthesia, allowing the whole procedure to be completed in the same day. Let us then turn our attention to our results. Amongst the 17 patients were 9 patients with cervical and segmental dystonia and 8 patients with generalized dystonia. They were all scored with Berg-Fan-Marsden Dystonia Rating Scale, the BFM scale, preoperatively and throughout the follow-up. This slide shows the BFM score for the patients with generalized dystonia preoperatively as compared with the latest control. The patients with generalized dystonia improved their BFM score significantly, and as the second slide here shows, the mean improvement was 68%. As you can see from this slide, the patients with cervical and segmental dystonia showed even more striking improvement as measured with the BFM score. In this group, the mean improvement was 80%. Again, this is preoperative BFM score as compared with the score at the latest follow-up. We have had no hematomas and no infections. The only complication in the group of 17 patients was a temporary edema reaction around an intracranial electrode, which lasted for about a week with no permanent sequelae. We conclude that DBS for dystonia at the National Hospital in Oslo is a safe and highly efficient treatment. On behalf of our multidisciplinary team, we thank you for your attention.